So there is venous drainage getting affected and the veins do not distend, they collapse the moment you elevate, or the moment the limb is elevated, the vein collapse. You and me, when we elevate our limbs, our veins don't collapse. They don't become a gutter. In a patient with a peripheral arterial disease, they become a gutter. You palpate both the, and of course you look what is the gangrene. This is all a part of infection. How much is a gangrene? What part is involved? Is it a dry gangrene? Is it a wet gangrene? I hope you know the difference between dry and a wet gangrene. What is the line of demarcation? Palpate the two sides, normal first and normal later, temperature gradient. Which side is cooler, till what level? Having done that, then you come to the examination of the pulsation. And the dorsalis pedis artery is best palpated, either the patient is sitting or the patient is lying. You dorsiflex the foot gently. It is a continuation of anterior tibial artery. Before it forms a deep plantar arch with tibial artery, it dips through the first intermetatarsal space. It is in the proximal part of the intermetatarsal space you palpate the dorsalis pedis artery against the shaft of second, what do you call this? Metatarsal. You do not palpate against navicular. One way is lateral to the tendon of extensor hallucis longa, and this is when you do a dorsiflexion, you can see the tendon of extensor hallucis longa stands out. Put out 3 fingers in the first intermetatarsal space. In the proximal part of the first intermetatarsal space, you palpate against the shaft of second metatarsal. Is that clear? Yeah, alright? Yeah? Having done that, some people say you should palpate the anterior tibial artery. Anterior tibial artery is palpated. Anterior tibial artery is palpated on the level of ankle joint. It is only palpable in 13 to 15% of the population, so you can ignore about it. Don't utter an examination. Don't say that I palpated anterior tibial artery or I did not palpate anterior tibial. The fact that you have palpated dorsalis pedis artery is a clue that anterior tibial artery is palpable. Then you palpate the posterior tibial artery, which is between the posterior border of the medial malleolus and the tendo-achilles. Midway between the two, you palpate against calcaneum, the posterior tibial artery. Is that clear? Posterior tibial artery is palpated midway between the posterior border of medial malleolus and the tendo-achilles. Further up is the popliteal artery, which is the most difficult of all the vessels to be palpated. There are 2 ways of palpating a posterior popliteal artery. Either with the patient lying supine, you flex the knee joint by about 45 to 60 degrees and put your finger in the popliteal fossa and palpate against the condyles of tibia, midway between the 2 gastrocnemius. If you can't feel like this, put a patient in prone position, particularly. Again, you passively flex the. ढीला छोड़, इसको ढीला छोड़।
सर कुछ जख्म।
हाँ, नहीं कुछ नहीं करेगा उसको ढीला छोड़, ढीला छोड़, बिल्कुल ढीला छोड़। Passively flex the limb at knee joint, 45 or 60 degrees. Put your finger in the upper half of popliteal fossa. This is where popliteal artery is in relation to the popliteal surface of the femur, the shaft of femur. In this part of the femur is like this. It's got an anteromedial, anterolateral, and it's got a popliteal surface, which is a triangular one, which is just above the condyles. Popliteal artery is not related to any of the condyles of femur. It is a continuation of femoral artery through the Hunter's canal as it comes out, and you palpate against the popliteal surface of the femur. Is that clear? Upper half of popliteal fossa. When you palpate in a prone position, it is in the middle of the popliteal fossa against the condyles of tibia. See those. Another way to find out whether popliteal artery is patent or not is ask a patient to sit cross-legged. You will see that there is a pendular movement of the limb which is resting on the other lower leg. Then comes the femoral artery. Femoral artery is palpated at a mid-inguinal point below the inguinal ligament with the limb slightly abducted and externally rotated because femoral artery is palpated against the head of femur. And in a normal posture, head of the femur is inside the acetabulum. You want to palpate an artery against the head of the femur, you have to take the head of the femur out of the acetabulum, and this is a posture in which the head of the femur comes out of the acetabulum, and then you palpate the mid-inguinal point below the inguinal ligament, the femoral artery. Shall I repeat or is that okay? Is it okay? Above the femoral artery are two pulsations which can be felt. One is external iliac artery and second is common iliac artery. External iliac artery, the fact that you can palpate the femoral artery means external iliac artery is palpable. Otherwise you can palpate external iliac artery against the pubic arch. Common femoral artery, if you remember the surface marking of the aortic bifurcation, which is about an inch below and to the left of umbilicus, the aorta divided into two. From here you join to the mid-inguinal point on either side. The proximal third of this is a common iliac artery, and it is palpated against ala of the sacrum. This is important especially when you are dealing with a patient who got atherosclerosis. Aorta, abdominal aorta is palpated just above and to the left of umbilicus against the lumbar vertebrae. These are the pulsations in the lower limb which they will have to palpate. In the upper limb, external iliac is just above the inguinal ligament. The point and joined to the mid-inguinal on either side. The proximal one third represents the common iliac artery. Right? In the upper limb, again you start from periphery and come to the central side. First is radial. I don't know what is the problem. People can't describe how is the radial palpated. Radial is palpated against the anterior surface of the lower part of the shaft of radius, not against any other structure. Not a radial styloid, not a radial tuberosity. As the radius comes down, the lower part of it is quadrilateral. It's got an anterior surface, got a posterior surface, got a lateral surface, got a medial surface. The medial surface articulates with the ulna, it's got a facet. The lateral comes down and forms a radial tuberosity. The posterior is in relation to the extensor muscles, and it is against the anterior surface of the lower part of the shaft of radius that you palpate the radial artery. Ulnar is often not palpated, but if you want to palpate and you want to connect that are palpated, either you palpate against the hook of Hammett or you palpate against the pisiform bone. Best is, say I have not been able to palpate ulnar. Okay, the moment you enter hook of Hammett or a pisiform, you can be asked a potential anatomical question as to what is attached to these two bones. Then comes the brachial artery. The brachial artery can be palpated at two places, A in the cubital fossa and B in the upper arm. You gently flex the elbow medial to the tendon of bicep brachii. You palpate brachial artery against one by one.
Lower end of the shaft of the ulna.
What do you mean lower shaft of the ulna? Ulna is here. Lower end of the humerus is very complicated. It's got a medial condyle, it's got a lateral condyle, it's got a medial apicondyle, it's got a lateral apicondyle, it's got a trochlear fossa, it has got a capitulum, it has got a what do you call it?
Olecranon.
Olecranon. Now olecranon is a part of
Posterior spinal.
so against what structure? No. Medial condyle is here. You palpate against the trochlear fossa. Capitulum is lateral. Capitulum articulates with the radius and artery is much more medial. So you palpate against the trochlear. If you want to avoid this anatomical controversy, best is I palpated the brachial artery in the middle of upper arm, medial to bicep brachii against the shaft of humerus. Because here, if you do not know the anatomy, you can get into a mess. Is it right? Middle of upper arm, against the shaft of humerus, medial to the bicep brachii, you palpate the brachial artery. Put के back. इसको डालो short video. And you want to avoid an anatomical discussion. Axillary artery becomes a brachial artery at the lower border of teres medial, which is inserted into the bicipital groove. Now, artery is on the medial side and bicipital groove is anterior. The two structures which are present here are head of the humerus, you got an anatomical neck of the humerus and you got a shaft. Now anatomical neck is just a thin rim of a bone and head of the humerus is not related to an artery at all. Unlike femoral artery, which is inside, femoral head which is inside the acetabulum, the humeral head is too big and it doesn't fit in relation to the glenoid cavity, so it's projecting upwards immediately. So you don't palpate against that. Anatomical neck is a very thin rim of a bone and you can't palpate against that. Shaft of the humerus is too broad in the upper part, you can't palpate it. So the only structure left behind is surgical neck of the humerus. Now surgical neck of the humerus, if you remember, this is a humerus. On the medial side, the capsule of shoulder joint extends down by 1.5 centimeters or 2, while the synovial membrane is only attached along the anatomical neck. Now that portion of the upper part of the shaft of humerus is called as surgical neck of the humerus, and it is palpated either if you stand in front or you stand at the back and palpate against the surgical neck of the humerus. It is the third part of axillary artery that is palpable. Axillary artery is divided into three by pectoralis minor, the part proximal to it, the part behind it, and the part distal to it. So it is the third part of axillary artery you are palpating against surgical neck of the humerus. Now axillary artery is nothing but a continuation of subclavian artery. At the outer border of first rib, the subclavian artery becomes axillary artery. Now subclavian artery itself has got three parts. First part, second part, and then third part. The first part is intrathoracic and cannot be palpated. The second part is behind the scalenus anterior, so you can't palpate it. It's only the third part of axillary artery that is palpable. And we have just mentioned that axillary artery becomes subclavian artery, or subclavian artery becomes axillary artery at the outer border of first rib. So the first rib is horizontally placed, unlike the other ribs which are obliquely placed, which have got a superior surface and an inferior surface. So you put your three fingers along the medial one-third of the clavicle. Just above that, you palpate subclavian artery against the superior surface of the first rib. It is the third part of subclavian artery which is palpable. Like in axillary, it's a third part of the axillary artery that is palpable. Is that clear?
Subclavian, third part of subclavian.
Subclavian artery has got three parts. The first part is intrathoracic. The second part is behind the scalenus anterior. And is the third part of subclavian artery which is lateral to the scalenus anterior, which at the outer border of first rib becomes the axillary artery. Because it is in the outer border of first rib, axillary artery is becoming or is getting a nomenclature after it is taken off from the first rib. So you can't palpate axillary artery. So what you are palpating is subclavian artery. The third part of subclavian artery you are palpating against the superior border of first rib. Have I made it clear?
Yes, sir.
Huh?
Yes, sir.
Now, after ये उधर से दिखाऊं कि इधर से नहीं आएगा ना?
घुमा दीजिए,
नहीं,
कहीं से भी दिखा दीजिए।
हाँ. You stand behind the patient, put your three fingers in just superior to the middle third of clavicle, middle third of the clavicle, dip it against the first rib you are palpating the subclavian artery. Then comes the common carotid artery, which is palpated along the anterior border of sternocleidomastoid at the level of cricoid cartilage against
transverse
a tubercle which is present on the anterior surface of transverse process of C6, which is also called carotid tubercle. At the upper border of thyroid cartilage or at the level of hyoid bone, it bifurcates into two. An internal carotid artery cannot be palpated in the neck. It is too deeply situated. The other importance is internal carotid artery has got no branches in the neck. External carotid artery by itself cannot be palpated in the neck. You can palpate the branches of external carotid artery, one of which is facial artery, which can be palpated against horizontal ramus of the mandible, just anterior to anterior border of masseter, like this. I have to look. Okay, like this. This is the anterior border of masseter. You palpate along the horizontal ramus of the mandible. You can palpate your own facial artery.
Yes.
Further up as you go, in the substance of parotid gland, the external carotid artery divides into two branches, internal maxillary and superficial temporal. Internal axillary is too deeply situated, goes medially and cannot be palpated. So the only vessel that can be palpated is superficial temporal artery. Either you can feel the main trunk of the superficial temporal artery against the zygomatic process, or you feel anterior branch of superficial temporal artery which runs along the hairline. You put your 3 fingers and you can palpate the superficial temporal artery. Right? These are the pulsations that are to be examined in any case with a peripheral vascular disease. In addition to that, all patients with peripheral vascular disease must have a neurological examination, because when diabetes manifests in the form of a peripheral vascular disease, patients often have associated neuropathy. Sometimes the claudication, so-called claudication, may be a pseudo-claudication, which may be not of an arterial origin, but may be of a venous origin, or may be of a neurogenic origin. So you have to examine the neurological system. All cases of peripheral vascular disease, you must auscultate the chest and try to look for apex beat, and if you can auscultate the heart. That will give you a clue whether the heart is enlarged, whether the heart has got associated valvular disease, or the heart has got any associated functional murmur. That is what completes the examination of any patient with a peripheral vascular disease. Any question?
Sir, external carotid artery palpated against what?
External carotid artery cannot be palpated. It's too short an artery, it immediately starts dividing. And the main trunk of external carotid artery ascends up, and in the substance of the carotid gland divided into two. Superficial temporal artery and the internal axillary. It's the superficial temporal artery you are palpating. It's not the arch of, it's not the, zygomatic. It's the temporal mandible joint against that you palpate. Because it's behind the arch, or deep the arch goes as anterior and posterior branches of it.
So we also need to see radio-radial delay and
You see, you often mention about radio-radial delay or radio